Hello there, welcome everybody. Thank you so much for joining us. We will begin the webinar promptly at 7. So thank you so much for those of us who've joined a little early. I will just take the opportunity to run through a little bit of the housekeeping before I hand over to Dr. Patrick. So we are muting participants for this presentation, but we would absolutely love it if some people are happy to keep their cameras on. It would be really nice to see some faces and, you know, have a bit of an interaction that way. Just to make you aware, this webinar is being recorded, so your image would be recorded if you keep your camera on. We will have a Q&A section from half an hour at the end, so at 8 o'clock we will go to the Q&A, and that part will not be recorded, so we won't record any of your questions, so we'll stop the recording at that point. So just to say that we will welcome people from all backgrounds. This is a safe and inclusive space, and ask that you're respectful and kind at all times. We refer to the term women throughout the presentation, and this will cover trans men, non-binary and intersex individuals, and any others who experience any of the issues discussed. So just to make you aware, Dr. Patrick does not have access to anybody's individual patient records here. So this is not a consultation, but an information webinar.
Sarah, that's great. Thank you very much. And thank you all for coming tonight. Brilliant to see you. Okay, it's dark, it's blooming freezing. I hope you're all snuggled up, nice and comfy and warm. Please get a drink, cup of tea, glass of wine, whatever you fancy. I've just got water, bit dull, but I do have my nice woolly socks on. So I intend to be very comfortable for the next hour and a half, and I hope you will too. I also hope that you find this a really worthwhile use of your time. Okay, I'm hoping that you'll find it very helpful. So my name is Dr. Kathryn Patrick, as Sarah said. Now, I have been a doctor now for coming up 25 years, and I have been a GP for, oh gosh, coming up 18 years now. And throughout my time as a GP, I've had an interest in women's health and in particular menopause as well. And for the last 6 years, I've also been working at Yeovil Hospital here as Director of Primary Care. So, why are we here tonight? Why bother? And what exactly are we talking about? Okay, so we're going to talk about menopause tonight. So what is menopause? By definition, what is that? Well, menopause is when it's been more than a year since a woman's last period, when there's nothing else contributing to that. For example, she might have like a hormonal method of contraception, you know, like an implant, or she might have a Mirena coiling. Now, I'm going to be really honest with you, okay? When I was a junior doctor, which admittedly, I've just told you, that was a quarter of a century ago. It's a long time ago. But when I was a junior doctor, we were taught, right, so basically when a woman gets to the menopause, the periods stop and she has hot flushes. End of. Next. That was it. Okay. Now, fortunately, we now know as a profession, we're much more enlightened, much more knowledgeable, and we are aware that there's much more to it than that. Okay. So the symptoms of menopause can have significant detrimental effect on the quality of life. Okay. Now, I've got to be dead honest with you here. I am a woman the wrong side of 45. So I have a vested interest in nailing this topic. Okay. Now, I used to start my talks by saying this is rapidly approaching on my horizon. It might be here in 6 months. It might be here in 6 years, but it's rapidly approaching. Well, ladies and gentlemen, and everybody else who's joined us tonight, let me share with you, I have been well and truly hit by the perimenopause sledgehammer myself. So I'm not only talking to you this evening as a doctor with a lot of experience in this area, I do also know on a personal note a lot of what you've all been experiencing, what you may experience. Okay, so I use the term perimenopause there. What does that mean? Well, perimenopause is basically when a woman is having the symptoms, menopausal symptoms, but she's still having periods, okay, even if they're few and far between. Okay, now we know that perimenopause on average lasts about 3 to 5 years, but it can go on for up to 12 years. So that's an awful long time. Now, fortunately, I think, I'm sure you'll all agree, we've got less of a stigma now in society, haven't we, about talking about menopause? And that's partly due to largely, I think, due to the fact that we've had increased presence, haven't we, about menopause in the media. and on social media. So Davina McCall's made a couple of documentaries, which I'm sure you've seen. BBC have run several different campaigns about menopause awareness, but that's not always been the case, has it? Now, think back to our mother's generation. Now, I don't know about you lot. Personally, I was brought up in a very, very strict Catholic upbringing where you did not mention anything like menopause. And in fact, I have got very, very vivid memories of my mum talking to her friends and her sister about another friend they were quite worried about because she had menopause. Sorry, what? She's got a problem with the period. It's menopause. It was all hush hush, wasn't it? Well, thank goodness we are not there anymore. Thank goodness we can now talk about these things and we can help each other out. Now, not only do menopausal symptoms have a significant effect on daily quality of life, they can have a massive impact on the workplace as well. Do you know 10% of women will actually give up work because of their menopausal symptoms, and 50% of women will consider giving up work. Now, bearing in mind, this is a time in a woman's life when she's pretty much top of her game, isn't she? So what a loss to the workplace. So part of the campaign that I'm joining my fellow menopause clinicians and managers, I hasten to add as well, is about increasing menopause awareness in the workplace, okay? And I urge you to do the same. You can take away nuggets from tonight and share them with your colleagues at work. Now, I want to talk to you about menopause in evolutionary terms, okay? So what do I mean by that? Right, let's go back 120 years, okay? So in evolutionary terms, 120 years is what? A nanosecond? Less than a blink of an eye, isn't it? 120 years, your average age of menopause was 51, okay? Your average life expectancy was 59. Because let's be honest, by that stage, most women, I don't know, you would have died of syphilis, sepsis, or I don't know, been run over by a horse. But 59 was our life expectancy. Let's fast forward 120 years, okay, to now, okay? Average age of menopause, still 51. Average life expectancy, 83. So essentially, we are now living over a third of our lives post-menopausal. I mean, that is huge, isn't it? The repercussions of that are massive. Now, I'd like you to take a look for a moment at this very, well, as I call it, Dr. P's not very scientific at all slide, but gives you the general idea. Okay, so what we've got on one axis, we've got your blood level of your hormones, and on the bottom axis, we've got time. Okay, so this is years, time in years. So if you look at the beginning, we've got a blue line is our estrogen, and the red dotted line is our progesterone. Okay, so when we grow up, we hit puberty, our hormone levels increase, don't they? And then they plateau off for a little while. Now look what happens to that blue line. Okay, as your progesterone just gradually decreases with age, oh my goodness, your estrogen is decreasing, but it's not doing so in a nice, neat diagonal line, is it? Oh goodness, no, it is up and down, peaks and troughs, peaks and troughs. It's a bit like the stock market, you know, you might have that overall trajectory in the same direction, but it's peaks and troughs along the way. Now, this explains the reason why I've done this slide, even though it's not very scientific, but it does give you the general idea, because I think it explains rather nicely why when you're having your perimenopause, you have a lot of ladies will feel, oh, do you know, I was all right last week, but I feel terrible this week. Or even, I was all right yesterday, but I feel terrible today. And that explains it with those peaks and troughs, okay? Now, as well as our fall in estrogen causing this whole myriad of symptoms, which I'll come on to in just a moment, we've got to remember as well that the fall in estrogen also affects our bone mineral density and our cardiovascular health, okay? So as our estrogen falls, our bones start to thin, and that puts us at an increased risk of osteoporosis. At the same time, our cardiovascular disease risk goes up as well, okay? And that's for lots of other reasons, which I'll come on to in more detail in just a moment. But essentially, we need estrogen for cardiovascular health, okay? So how do we diagnose menopause? Right, you may have heard of a blood test, and some of you might be thinking, well, why haven't I had a blood test? Or I'd like to have a blood test. Let me explain it, break it down for you. So there is a hormone called FSH, follicle stimulating hormone. And that is a hormone that the pituitary gland at the base of your brain produces. And that kickstarts your ovaries. Okay. Now, we check this hormone if a woman is under 46. So if a woman is having a menopause under the age of 45, we call that an early menopause. If she's under the age of 40, we call that premature ovarian insufficiency, or POI for short. Okay. Now, and we have to be really careful how we interpret an FSH blood test. Okay. Essentially, what happens is, as your ovaries produce less and less estrogen, your pituitary gland goes, come on, let's make more FSH. Come on, ovaries, come on. And they make more FSH to try and stimulate those ovaries more. Come on, let's make more estrogen. Meanwhile, your ovaries are going, oh, I can't make any more estrogen. I've run out and I'm tired. So therefore, your pituitary gland makes more FSH. Okay, so if a lady's FSH is high, that's useful. It tells us, okay, yeah, she's perimenopausal/menopausal, okay? If it's normal, it doesn't tell us one way or the other. Because remember my not very scientific slide, those blue lines and the peaks and troughs, yeah? It might be that the day that she had that blood test done, her estrogen was at a peak, and that caused her FSH to be low. Okay, so I'm putting that out there just to let you know, be careful how you interpret it. Okay, if I have a patient, so for a start, we should only be checking it if she's 45 or under. Okay, if it comes back as normal, what I say is, okay, be helpful if we can repeat the test 6 weeks later. Okay, the idea being that should be theoretically a different point in a cycle. But here's the crucial bit, right? We do not sit around waiting for a high FSH. Okay, we look at the clinical picture, we look at her symptoms, okay, not just her periods, because we might not have the luxury of being able to look at her period pattern, because she might have a Mirena coil, she might have the contraceptive implant, or she might have a contraceptive pill. Okay, so we look at these other symptoms. All right, so we don't sit around waiting for a high FSH. It's useful, careful how you interpret it, but don't sit around waiting for it. Okay, why do we bother classifying? Why do we break this definition down into early menopause and POI? Why do we do that? Tell you why. It's the real important thing here is, remember what I said before about how when our estrogen falls, our cardiovascular risk is increasing, our osteoporosis risk is increasing. Yeah. So these younger women, we really want to be able to pick them up and identify them and get that estrogen replacement on board sooner rather than later. Because if you can imagine the consequences, if your bones start thinning at 35 compared to if they start thinning at 55, that's quite a big difference, isn't it? Okay. So what are the symptoms? Right. Golden rule of PowerPoint presentations. Don't do a busy slide. Okay. However, I have deliberately made this slide busy. Okay. And I've done that because I want you to be able to see just bang, 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 bang. Look how many symptoms there are. Do you remember what I said quarter of a century ago? Me as a junior doctor on the wards being told, right, okay, Dr. Patrick, when a woman has her menopause, she'll have a few hot flushes and a periods will stop. That's it. Okay. No. There is a lot more to it than that. Have a look at this list. Right. Vasomotor, very fancy phrase, or very fancy word for saying hot flushes and sweats. Okay. Fatigue can be overwhelming. And I am talking, I could lie on the floor and go to sleep now. I don't think I can even make it to my bed. Okay. Irregular periods leading to amenorrhea. Thing about medicine, right, we like to have fancy terms for things that are not necessarily that fancy. And amenorrhea just literally means your periods have stopped. Okay, so amenorrhea. Vaginal atrophy. Again, another fancy title. I just think it sounds horrible, doesn't it? It's literally when you get thinning of the tissue around the vagina, the skin around there, and that can cause itching and soreness and vaginal dryness. Urinary symptoms, so a bit of leakage, particularly when you cough, having to dash to the loo, feeling like you need a wee every 5 minutes. Anxiety, this is huge. Do you know what? I honestly, I have women whose anxiety has been absolutely debilitating, causing them to have to take time off work. They can't function. Loss of confidence. This is a big one. I see this a lot. I had one lady who, she's not in Somerset, by the way, this is when I worked somewhere else, who was had a really senior job in the corporate world. You know, this woman could command a boardroom, no problem at all. I had her she was in my room in bits. She was just in tears saying, I'm getting anxious, like driving to my friend's house, driving to blooming supermarket. You know, this is real. It has a real impact on quality of life. Low moods, including mood swings, palpitations. I've inherited a lot of ladies who've gone quite far down the cardiology route, having all kinds of investigations, when actually she doesn't necessarily need an echo. What she needs is a bit of estrogen. Now, don't get me wrong, right? If you come to me, if I was your GP and you said, oh, Dr. P, I've been having palpitations, I'm not going to look at your age and go, oh, well, Mrs. Bloggs, you're 48, let's just talk menopause. You know, of course not. I'm going to actually have a look and make sure I'm not missing any cardiac pathology. But at the same time, I've got in my mind, okay, while we're looking at that, let's explore whether you've got any perimenopausal symptoms and whether we need to be replacing your estrogen here. Dry skin can cause a lot of itching, that like really, really dry. The problem when we have itchy skin, we scratch the skin, the cells open, release histamine. Histamine promotes further itching, further scratching, more cells open, more histamine released. You can see that itch scratch cycle going on there. Bowel symptoms, we have lots of estrogen receptors in our bowels, so it can cause worsening of not just irritable bowel, but women who have inflammatory bowel disease, things like Crohn's and ulcerative colitis, that can get worse at the time of menopause as well. Hair sprouting. Now, this is something you don't talk about in polite conversation, is it? Right? Being a doctor is a privilege, and it gives you a privileged window into people's lives. And I often say to my ladies, do you know what? I know what's normal because I know what's coming through my door every single day. Okay. But people don't necessarily talk about these things with their girlfriends. Now, I am going to share with you a story about my boy who is 14 and will die a death if you knew I was talking about him tonight. Now, when he was 3, I was dropping him off at nursery. And so I would have been like, what would I have been, like mid-30s at the time. And I dropped him off at nursery, and the manager, who the owner of the nursery, she would have been in her 50s at the time. And for some reason, God only knows why, what made him think of bringing this up, he said, my mummy puts hot wax on her eyebrows here and her eyebrows here, and then she rips it off. And I thought, oh my gosh, I was absolutely mortified, right? I just wanted the ground to swallow me up. And this woman, I've never forgotten what this woman said, because she did wonders for making me feel more comfortable. She bent down to my son and she said, well, Jack, you just wait till your mummy gets to my age, because then she'll find she has hair sprouting out of all sorts of places you never did imagine. So it is more common than you think. I imagine not many of your girlfriends would pick up the phone and say to you, sorry, I can't come for coffee tomorrow. I've got to stay home and wax my tash. But trust me, these things are happening, okay? Now, next, MSK pain, musculoskeletal pain. Likewise, with my cardiology lady I mentioned, I've actually inherited quite a few ladies who've gone down quite far down the route of rheumatology and even orthopedics, looking at having joints injected. And it's actually, those joints need estrogen replacement. So bear in mind musculoskeletal pain and memory problems, or as I like to call it, loss of nouns. You know, pass me the, whatchamacallit? It's on top of the thingamajig. Just the word just goes. And you know what, this particularly happens with names actually as well. And I have experienced this myself. I've been in a board meeting and I've been asked, you know, whether I'd followed up a project, and I had. God, I'd been such a Girl Scout, goody two shoes. I had done all the work. Could I remember the name of the doctor that I'd been liaising with? You know, really difficult. Now, fortunately, I am flying the flag of menopause awareness in the workplace. So I'm quite happy to say to my colleagues, hang on a minute, let me dig out the email because the name's just gone for a moment. So please don't be embarrassed to do that. You know, this is normal. We have ways and means of making sure we can still function. Okay. But memory problems, it can be a real thing, you know, and it is a real thing, I should say, but it can be really debilitating. Now, do you remember what I mentioned earlier about how 10% of women will actually consider giving up? Well, they will give up work because of their symptoms, and 50% will consider giving up work or reducing their hours. Overall, 80% of women going through the menopause will have at least some of these symptoms. In my experience, they have most of them, okay? And for 25% of women, these symptoms will be severe, okay? So it's really important we take this seriously. Now, I'm going to talk about GSM, okay? Genitourinary syndrome symptoms of the menopause, okay? We used to call it vaginal atrophy, and then we twigged, oh, it's actually the bladder as well. It's not just the vagina. So let's have a quick run through these, okay? We've got estrogen and progesterone receptors in our vagina, bladder, urethra, and pelvic floor, okay? Now, the vaginal epithelium becomes thin. It loses its collagen support and its elasticity. You get change in pH because if you reduce lactic acid, you get change in vaginal and cervical secretions. So what does that cause? Well, vaginal soreness, itching, superficial dyspareunia, another fancy word, basically saying pain on sex, okay? For the bladder, urgency, so having to dash to the loo, needing to wee, you know, 100 times a minute, repeat bladder infections, leakage, feeling that you've not emptied your bladder fully. And we do see increased prolapses at this time of life as well. Right, here's my tip on when you go into the toilet if you're perimenopausal. I'm going to try and demonstrate. Don't worry, not too far. Okay, so most women go on the loo, have a pee, and then they're dashing off, aren't they? Right, okay. Instead of doing that, sit on the toilet. I want you to rock on the toilet, okay? So lean all your weight forwards, lean all your weight backwards, all on your right thigh, all on your left thigh, but don't do it that quickly. Do it for about 10 seconds each time. You'll be surprised at how much wee still comes out. So you think you're finished, you think your bladder's empty, and it's not. So top tip, rock on the toilet. Now, these urogenital symptoms will affect 50% of menopausal women. Here's an interesting fact for you. Women who are already steady on HRT, they're taking HRT, they've titrated it up, they've got the right dose for them, a quarter of those women will still need additional estrogen delivered to the vagina. Okay, now there's different ways of doing this. We've got vaginal pessaries. I'm going to hold this up. Can you see this blue applicator? Can you see it's got a little white dot at the end there? That's the pessary. Okay, there's another one here. So this one doesn't have a plastic applicator. Okay. The treatment for vaginal estrogen is to use it every night for a fortnight and then twice a week ongoing. Okay. I'll be perfectly honest with you. I think we should all be investing in our vaginas, quite frankly. And I personally would like to buy vaginal estrogen for each and every one of my girlfriends for her 45th birthday. Happy birthday! Please take care of your vagina because it's really important. It really is. And not just the bladder side of things, but that itching and that soreness can be horrific. I've got one lady who described the soreness to me as it's like someone is holding a blowtorch down there. I've got another lady couldn't wear jeans for about 3 months until she'd got her vaginal estrogen replaced sufficiently. Okay, it's real stuff. You know, I've got one poor woman. Right, she basically she was so limited for how long she could wear underwear for. She said it's like somebody's put sandpaper in the gusset of my knickers every time I walk. So she would plan her day as, right, I need to leave the house to go to that meeting, or I've got to go to the supermarket. So that's the only time I can leave the house in the day because I'll be out the house for 2 hours. I can't stand wearing underwear for any longer than that. Right, that's awful, isn't it? It's really horrendous. Now, if a woman is having vaginal dryness predominantly, I'd go for a pessary for her. If she's having more itching or soreness, I'd go for a vaginal cream. And this one's dead easy. It does come with an applicator, but can be a bit fiddly. So you tend to say, put a blob on your finger up into the vagina, wiggle it around, and as you bring it out of the vagina, rub it on the labia like that. Okay? There's also a lot of lubricants available. Please be careful. Don't buy anything that is like looks like it's oh, buy this. It's got really pretty packaging and it's a lovely colour and it smells really nice. Avoid those like the plague, because the fact they are a lovely colour and they smell really nice means they've got irritants in them. Okay, they're more likely to make it worse. There's a brand here called Silk, SYLK. There's another brand called Yes. Okay, these are the ones that we recognise as being safe and non-irritants. Okay. Coconut oil, that's another good one. Cheap as chips. Really, really useful. Okay. Now, I'm going to talk to you briefly here. Look, can you see that I've put this in bold? Do not forget your pelvic floor exercises. I think generally, as a rule, we're quite good at doing pelvic floor exercises. Those of us who've had children, quite good at doing them, aren't we, when we've just had a baby? And then you just sort of forget, really, don't you? And like life gets in the way. Yeah. So please, 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 we're investing in our vaginas. We're investing in our pelvic floors. Okay. Please do your pelvic floor exercises. Now, you know, when we finish the webinar, right, over the next few days, we'll be able to send you a list of reputable resources. And there's a really good link that I've got in there about pelvic floor exercises. I've written in there about over-the-counter weights. Okay. And the reason for that is if you can buy these weights, they look a little bit like that pessary, actually. And there's different weights, you know, some start off quite light, they get heavier and heavier. It's a bit like, you know, if you want to get shutter bingo wings, right, you're not just going to do that all day, are you? You're going to have a dumbbell. Yeah. So it's the same theory. If you have a weight, then the vaginal muscles have got to work harder. Okay. Now, I'll be honest with you, right, when I went to, you know, my boy, who I'm not supposed to talk about because he's 14 and he'll get embarrassed, but I'll talk about him anyway, right? When I had my boy, I went for my 6-week check at my GP's and she said, are you doing your pelvic floor exercises? To which I said, yes, because of course I wasn't I? Because we're all good at doing it when we've just had a baby. Do you know what? She leaned over the desk at me and she went like this. And so you must continue to do so religiously until the day you die. Oh my goodness, put the fear of God in me, terrified me. But I tell you something, she was so correct. She was absolutely correct. We really do need to, because actually we should be doing it at a younger age. I see in my job a lot of ladies in their 60s, 70s, 80s, sometimes younger as well, but more so 60s, 70s and 80s who've got terrible trouble with prolapses, and this can all be avoided, you know. But as I say, be careful what you look up. Please use our reputable resources, because I've got another lady I want to tell you about who's absolutely fantastic woman, brilliant at self-care, really wants to help herself as much as she can, but she's not very IT literate. And she came to see me, say, look, I didn't want to bother you because I know you're so busy, but I think I've got a prolapse. And I said, okay, that's fine. We can have a look. I'll examine you. And, you know, let's see what we find and what we can do. And she says, the thing is, because I didn't want to bother you, I did go online to try and help myself. Well, God love it, this poor woman, she essentially Googled tight vagina and ended up with a search history any 16-year-old boy would be proud of. So please, reputable resources only. And we will be sending those to you. Now, this is the slide that I say anybody amongst us, right, who is in a heterosexual relationship, please sit up and pay attention right now. This is your contraceptive slide. Does a woman still need contraception if she's perimenopausal or menopausal? Yes, is the answer. HRT is not contraception. I've had probably about 5 women I've come across in my career who have got pregnant and they have not known they're pregnant because they've been in their late 40s. One was over 50, and they honestly thought it was perimenopause. So if a woman stops her periods under the age of 50, she still needs contraception for another 2 years. Okay. If she's over 50 when her period stops, she needs contraception for another year after that last period. Okay. So don't get caught out. Okay. Now I'm going to talk to you next about some common myths busted. Okay. Try saying that after 10 pints. Now, these are essentially, what I've put together here are just things that are commonly said to me by patients when they come to clinic. Okay. Well, you should wait, shouldn't you, until you can't manage any longer, until you get help with your symptoms. Oh, there's no point taking HRT. It just delays your menopause. Oh, you've got to stop it after 5 years. No, you can't take HRT, can you, if you've got migraine? Oh, God, if you take HRT, your weight will balloon. Right, now, did any of you watch Family Fortunes when you were a kid? Yeah. Our survey says, okay, so let's go through those. You can start HRT even when you are still having periods, when you're perimenopausal, right? And don't forget, when your estrogen's falling, your osteoporosis risk is going up, your cardiovascular risk is going up. So actually, it's prudent to start it sooner rather than later, okay? If you're getting symptoms when you stop HRT, guess what? You would have had symptoms before. And actually, you know, like if you'd never taken HRT, and in fact, for those women who do decide to stop HRT, you can wean it down gradually, can't you? Unlike if they're just dropping of their own accord. And remember those peaks and troughs. Now, there is now no maximum amount of time that a woman can take HRT for. It depends on her individual circumstances. It's all about risk, weighing up risks and benefits and personal choice, okay? Women with migraine can take HRT, but they should take it through the skin. I'm going to come on to that in just a moment. Transdermal estrogen through the skin, okay? The weight issue, God, I reckon if I had £1 for every time I was asked about weight gain and HRT, we'll put it this way, I wouldn't be sat here tonight. I'd probably be in the Bahamas, okay? It is asked so often. Now, here's the interesting thing, okay? When our estrogen falls, our metabolic rate falls. That's why we gain weight. In addition, we get increased insulin resistance, which is why we tend to get the gain, you know, around here, around your middle. You know, you see people, we talk about that apple shape. You sometimes see these little old ladies, skinny arms, skinny legs, but really quite rotund around the middle. Okay. It's the fall in estrogen that's causing that. So actually replacing your estrogen means that is less likely to happen. Okay. Now, on top of that, replacing estrogen means a woman is no longer battling all those myriad of symptoms that we just talked about before. And if you're not battling those symptoms, if you're eating better, you're sleeping better, you're less anxious, your mood is better, okay? You're having a heart race and sweating, you know, several times a week or several times a day. You're much more likely to make better food choices, aren't you? You're much more likely to have the energy to exercise, okay? And there is really interesting data actually that supports that women who take HRT are less likely to gain weight, okay? Okay, so does a woman need to have HRT? Can she have HRT? If so, what sort of HRT should she have? Remember, we want to replace the estrogen, okay? We want to replace the estrogen to get on top of her symptoms. And she's also, so I break it down, right? 2 aspects. Over here is your symptoms. Over here is about replacing your estrogen so that you can be the best version of you, okay? You can be in a position where you're no longer having to deal with all those symptoms on a daily basis, okay? Over here is your other aspect of HRT, which is your future health. So we know it reduces risk of osteoporosis. We know it reduces cardiovascular risk, so heart attacks and stroke. We now have data emerging that shows us it reduces your risk of dementia and diabetes. But if a woman's not had a hysterectomy, she's still got a uterus, that's when we need to give progesterone, okay? Because if a woman's got a uterus and I just give her estrogen on its own, what happens is we run the risk of overstimulating the lining of the womb, okay, that endometrium. And if we overstimulate the endometrium, that can put her at risk of womb cancer down the line. So that's why we give the second hormone, progesterone, okay? So that explains if some of your friends, you might go, oh, my friend only has estrogen. Well, that'll be because she's either had a hysterectomy or she's got a Mirena coil fitted. Okay. So what types of HRT are there? There's topical, there's systemic, there's estrogen and progesterone, there's cyclical, there's continuous, combined, there's gel, there's patch, there's oral, there's spray. Oh my God, it's confusing. Actually, it's not at all. Let's just break it down. It's really simple. First thing, does she have a uterus? Second thing, when was her last period? Okay. Now, if she has still got her uterus, we need to give her progesterone. Okay. If she is still having periods, we give that progesterone in a cyclical pattern, okay? So I'm going to show you, because I have brought my goodie bag with me tonight with my samples. So let's talk estrogen first. Gold standard estrogen is through the skin, transdermal. Now that is because if we take estrogen orally, it goes via our liver. Our liver makes clotting factors. So with oral estrogen, there is a small increased risk of blood clots. It's only small, but it's there. If we have our estrogen through the skin, it's not there. So our options for that are, we have a gel here, and the gel, it's metered dose. So when you press it, 1 pump equals 1 dose. So you're not like squeezing it out going, oh, how much? It's like one pump equals 1 dose, okay? And a gel, we apply daily. And you rub it on your arms like this, or you can rub it on your inner thigh. So I tend to say to my ladies, like, when you get up in the morning, have your shower, put your gel on, go make a cup of tea, do your hair, whatever, it, 5-10 minutes while it dries, and then you can get yourself dressed, okay? So the other option through the skin is a patch. Now the patches come in a sachet like that, which you open up like that. I'll get this out. Can you see this? It's got a foil backing on it, this one. So when you take the backing off, it's actually see-through. Can you see that? Now patches are changed twice weekly, and when you put a patch, lower abdomen, thigh, buttock, okay? So daily gel, twice weekly patch, okay? There is also a spray that we use. We tend not to go for a spray as first line. We tend to use gel or patch first line, purely because the absorption with a spray is a little bit more variable. Okay, so that's your estrogen. What about your progesterone? Again, should we talk gold standard? Right? Can you see this? They look like little pearl capsules. They're quite pretty, actually, aren't they? So this is called Utrogestan, which is a body identical progesterone. Does what it says on the tin. It's identical to your body's own progesterone, okay? And there are 2 patterns of taking this. The cyclical, I've written up there, okay, and there's continuous combined. So cyclical is when a woman has 2 of these tablets every night for a fortnight, then 2 weeks off. And she restarts for a fortnight, 2 weeks off. So 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off. Dead easy, really easy, okay? And that puts her in a cycle where she has a monthly bleed. The other way of doing it is continuous combined, which is where you have 1 tablet every night. Bang, 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 bang. Okay, every night. Okay, so how do you decide which pattern is right for you? Ultimately, it's whether you're still having periods or not. Okay, so if a woman is still having her periods, we go cyclically first, usually for about a year, and then we review whether to switch her to continuous combined at that point. Because if you're still having periods and I give you that as continuous combined straight away, you're more likely to end up with an irregular bleeding pattern all over the place. And quite frankly, you wouldn't thank me for that, So that's why we tend to go, we look at, does she have a uterus and is she having periods? Okay. So that's our gold standard. Now, the other mechanism, the other very popular way of looking at your progesterone cover, okay, so we've got our body identical here, is a Mirena coil. Now, Mirena coil can be really particularly useful if a woman is perimenopausal, because it'll double up. You're killing 2 birds with 1 stone, because it's giving you your contraception and it's also providing your progesterone cover, okay, and that lasts for up to 5 years. Okay, for HRT. All right, it's licensed for 4 years, but we use it for 5 years for HRT. Okay, moving on. Now, drum roll, because I get asked about this so much. So I'm giving myself a drum roll here, because I bet you're all waiting for me to come on to this slide. Testosterone. I get asked so much about testosterone. I've been asked more about this in the last 9 months than I have been in the last 5 years. Okay, so testosterone is not just a male hormone. Okay, as women, we make testosterone, we make it in our adrenal glands and we make it in our ovaries. We know it promotes libido, orgasm, muscle strength, bone strength, cardiovascular health, cognition, and energy levels. Now, some effects are direct, so that's the testosterone acting directly on your tissues. And some of your testosterone will be converted in your peripheries to estrogen. Okay, now our level of testosterone decreases with age. There's been a lot more talk of testosterone in the last year or so, largely because of the media. Okay. Now, here's an interesting fact. Well, I find it interesting. Hopefully you will too. As women, before we reach perimenopause, we make far, far more testosterone per day than we make estrogen. So it's definitely not just one for the guys, it's one for the girls as well, okay? Now, there is no testosterone product currently licensed in the UK for women, okay? We have products licensed for men that we do use off license for women. And we are incredibly fortunate in Somerset that it's actually on our formulary as a green drug. So what that means is that we can prescribe it on the NHS in Somerset. Now, not all GPs will be comfortable prescribing it. And as GPs, as a GP myself, been a GP for nearly 20 years, it's so important that we only prescribe within our area of expertise and with our area of comfort, because we've got to be safe, okay? So some GPs are able to prescribe it, but not all. However, part of the work that we're doing in Somerset, myself in this role, my colleague, Dr Balfour, we are doing a lot of doctor and nurse and pharmacist, so clinician education, okay, on menopause, and we are doing a lot on testosterone, so this should become easier with time. Now, it's a gel and it's applied, I've written there, buttocks, thighs, inner farm, abdomen. I've put that on there because that's what you'll read in your leaflet. My top tip for ladies, if they are having testosterone, is to just put it on the thigh. And that's because you can sometimes get a little bit of increased hair growth at the site of application, or you can get a bit darker hair growth. Now, of course, if that's on your outer thigh, that's fine. If you've chosen to apply it to your buttock and you get a bit of increased hair growth there, not so good. Okay, side effect wise, most women are fine. They don't get any. Some might find they get a bit of acne, or the skin might be a bit greasy. They might feel slightly more irritable. We do blood tests beforehand, looking at a woman's testosterone level, and that's to make sure that she's not got a high testosterone to start with. And then we also do more detailed blood tests after a few months of using it. Again, we need to be really careful that we're keeping somebody within the female physiological range. And no, she shouldn't grow a beard, not unless she's rubbing it on her face. So top tip, don't rub it on your face. But no, shouldn't get a deep voice, shouldn't get a beard. So who should have it? Who should have testosterone? Okay, well, this is interesting because NICE guidelines, okay, say that we can give testosterone replacement to women for low libido, okay, but only if she's got her estrogen titrated, so she's on the correct amount of estrogen, okay, and only if everything else has been excluded. Libido is such a complex topic, isn't it? It's so complex. And if somebody's got relationship difficulties, it doesn't matter how much testosterone we throw at that person. It's not going to fix the libido, is it? And I mean, low libido can be really significant. It can have a really significant effect on marriages. You know, it can cause a real strain. If you think about all those other symptoms, those on their own can cause a strain in a relationship. If you then add in the factor that the woman going through that's got low libido, and by low libido, I mean really low libido, as in, you know, Brad Pitt is knocking on your door and you're inviting him in to do the ironing while you have a nap, you know, zero libido for a lot of ladies. So it really can have a detrimental effect. Now, that's NICE guidelines, libido only. What is interesting is that we are seeing emerging data, and this is very much watch this space, okay? There is emerging data that it indicates that it can also help with brain fog, cognition, and energy levels, and also with mood as well. So we just watch this space here. I think the next couple of years are going to be really interesting to see the research emerging from that, okay? Now, this slide I call my cowboys and quacks slide, okay? So this is my public health warning, okay? I'm going to talk to you very briefly about the terminology bioidentical hormone and body identical. What's that? That is quite confusing. Yeah, it is confusing. And it shouldn't be. So I'm going to demystify it, okay? Bioidentical, it literally means it's got the same molecular structure as the hormone in your body. Okay, well, that's got to be good, hasn't it? Yeah, it has. Okay, regulated bioidentical hormones, we are using the term body identical for ease. So body identical means it's regulated. The unregulated, we refer to as compound bioidentical. Now, the reason I've stuck this slide up here is, please, this is for you, your sisters, your wives, your friends, your cousins, your colleagues, okay, to protect them, because there are a lot of cowboys out there, there are a lot of quacks out there, and they are raking it in on these unregulated products that do not have an evidence base behind them and can actually be quite dangerous as well. Okay, so take home message: body identical, yay, good. Bioidentical, unregulated, bad. Okay, and when I say unregulated, do you know what? I even mean the factories that they're made in. Honestly, it's frightening, and it's because they're sold as a supplement. You see, not as a medication, and because it's not coming under the medicines umbrella, they get away with it. So please be careful. So what are the side effects? We'll have a look at this. Right, what a crossover: estrogen and progesterone. Fluid retention, breast tenderness, headaches. With progesterone, we often see the mood swings and PMT-like symptoms. Just be mindful of that. You can sometimes get that. It's not that common, but you sometimes can get that. But don't forget, you can alter your dose of estrogen and you can alter your type of progesterone. Now, I would say to my ladies, right, HRT is built on a rock solid foundation of science, without a doubt it is. But tailoring it to the individual woman, that is an art form. All right, it really is. Now, I thought it would be useful if I just touch very briefly, okay, on women with specific conditions, okay? But before I do that, can I put my BBC voice on for a moment, please? I would like to talk to you about post-menopausal bleeding. If you've dozed off before now, wake up. This is really important, okay? What is a post-menopausal bleed? It's when a woman has a heavy or prolonged, basically when she's bleeding after a prolonged interval, okay? Particularly if it's heavy, but any bleeding. Now, if she's not got HRT, this is important bit, she's not taking HRT, she stops her periods, and then more than a year later, she starts to bleed, we need to know about it, okay? She must get that checked out. More than 9.5 times out of 10, it's nothing, right? But it can be a sign of endometrial cancer, okay? So if her periods have stopped, it's been more than a year, and then she starts bleeding again, please tell us. You are not wasting our time. We need to know about these ladies. So what if she's taking HRT? Right, when we start HRT or we tweak HRT, it is really quite common to get funny bleeding to start off with. And do you know what? It can go on for 3 to 6 months even. So don't poo your pants if that's happening, okay? Don't get worried if that's happening, but keep a diary of it. And when you have your review, let the person you're speaking to, your doctor, your nurse, your pharmacist, make sure you tell them, okay? If it's going on for more than 6 months, then we will absolutely look into it further. Likewise, if it's heavy, so it might have only been going on for 4 months, say, but if it's heavy, we want to know, okay? I didn't keep that BBC voice up for very long, did I? But hopefully got the message across about how serious that is, okay? So let's just run through a few specific conditions. So what if a woman's had breast cancer? Well, HRT can be contraindicated with a woman with breast cancer. You can look at some antidepressants known as SSRIs if she's got symptoms of anxiety or depression. But just be careful, because some women with breast cancer will be taking tamoxifen, and some of these antidepressants, named like paroxetine and fluoxetine, can inhibit how tamoxifen works. So it's no good saying, oh, have this tablet, it'll help with your anxiety. Oh, blimey, in the meantime, I've made your tamoxifen less effective in treating your breast cancer. So if anybody's got a history of breast cancer and they think they would like to consider HRT, do reach out, do contact your GP. Your GP should correctly say, no, I can't do a prescription for you right now. That's correct. The GP says that, but it shouldn't be computer says no, end of. What it should be is, thank you. I hear that you've had breast cancer. I hear you would like to consider HRT. So let's set up a conversation with your oncologist and the menopause specialist. Okay. What if she's had blood clots? Do you remember what I said before about if you have your estrogen through the skin, there is no increased risk of blood clots, is there? Okay. So you only get an increased risk of blood clots if you've got oral estrogen. Okay. Now, women with a BMI over 30, they've already got an increased risk of clots. So they should definitely be having transdermal. But as I said, your gold standard is to go transdermal first line anyway. Okay. What about cardiovascular disease? Okay. Do you know what? I've actually inherited quite a few women who've been told they can't have HRT because they're hypertensive. It's not right. Yes, by all means, we absolutely need to control. We definitely need to control your blood pressure. I'm not going to go, oh, your blood pressure's high. Don't worry about it. You know, of course we want to address that, but we'd want to address that anyway, wouldn't we? Even if we're not even talking about HRT. Interestingly, when you start HRT under the age of 60 or within 10 years of your last period, it does not increase your cardiovascular risk. Okay, it does not. And in fact, estrogen helps with the elasticity of the lining of our blood vessels. It also helps with our good cholesterol and our lipids in our bloods. Okay, so actually those are two of the many reasons how HRT can reduce your cardiovascular risk. Okay, because that risk does go up after the menopause. Okay, what if she's diabetic? Again, patient's told she can't have HRT because she's diabetic. No, she can. We need to optimize their diabetes control. But again, we should be doing that anyway, shouldn't we? Even if she's not menopausal, okay? And don't forget what I said earlier. If a woman takes HRT and then is no longer battling all those symptoms, she's not knackered, she's sleeping well, her mood's better, you know, she's not anxious, she's more likely to be able to eat better. She's more likely to be able to exercise. She's less likely to self-medicate with a glass of wine and a pot of Pringles at the end of the day, which you can see why people do that if you're having a rough time of it and you're feeling lousy. What about endometriosis? Well, if a woman's had endometriosis, estrogen replacement can sometimes reactivate pockets of endometriosis. But let's also weigh that up against the fact that actually women with endometriosis, their treatment for endometriosis may well put them at higher risk of osteoporosis in the first place. Okay, so we need to bear that in mind. And there are various ways that we can tackle this. Okay, I've written down there continuous combined HRT. That's often better for these ladies. Tibolone, I've stuck that on there because sometimes I get asked about it. We don't really prescribe it much nowadays because it's more of an old-fashioned treatment. It's synthetic as well. It's not our body identical. Okay. Right. What about fibroids? Again, fibroids, not a contraindication. Fibroids can shrink by up to 40% in most women when they go through the menopause, right? Now, HRT might stimulate the growth of a pre-existing fibroid, but it will not create a new fibroid, okay? And remember your Mirena coil, okay? Because if a fibroid grows and it makes her periods heavier, ka-ching, if she has a Mirena coil fitted, that will get rid of that. Eventually, her period should stop with that. Now, I'm touching here on non-hormonal therapies. Again, some of you may have come across these. Clonidine, very old-fashioned blood pressure medication. Don't give it for blood pressure anymore because there's better blood pressure antihypertensives on the market. Antidepressants can be helpful. There's no evidence that says it's helpful in low mood if a woman's not actually got depression. Okay, well, hang on a minute. That's a bit of a grey area. How are we supposed to tell, oh, this part of your depression is related to perimenopause? This part of your depression / low mood you would have had anyway. Okay, but here's what I see a lot. A lot of ladies have gone quite far down the line of antidepressants. Some of them are even on their third one and they're not responding. And the reason they're not responding is because it's the estrogen replacement that they need. Okay. Now, there's herbal preparations I get asked about a lot, things like black cohosh. They're not regulated and they have different active amounts. So as NHS doctors, we can't comment on the safety of those. Okay, they're not evidence-based and they're not regulated. So you do need to be careful with them. But you've got to remember your best friend is lifestyle. So what do I mean by lifestyle? Right, you don't need a doctor to sit in front of you, do you, to go, exercise is good for you. We all know that, but actually, specifically, how is it good for menopause? Let me tell you. It increases your muscle mass. That in itself will push up your metabolic rate. So you're not only burning off calories when you're doing your exercise, but afterwards, your metabolic rate is up, okay? It increases your bone mineral density if you're weight bearing, and it also increases those feel-good hormones in the brain, okay? So I advise that you balance an aerobic training with some strength training, and yoga and Pilates can be brilliant here. Stop smoking. Again, don't need a doctor to tell you that. Smoking has a direct effect on hot flushes, as well as obviously the direct effect on other health factors, isn't it? Health risks. Healthy diet. Remember what I said before, estrogen falls, you get increased insulin resistance, you get that apple shape. Reducing your carbohydrates and upping your protein can really help here. Reducing alcohol and caffeine and spicy foods as well, because they can directly trigger your hot flushes. Now, listen, you can laugh at me saying this to you, right? I apologise in advance that I am sat here in front of you saying, hey, please minimise your external stresses. And you're sitting there going, are you serious, Dr. P? Have you seen the cost of living crisis? There's a war in Ukraine and COVID is still around. Okay, I get that totally. Let's look at the external stresses we can control, okay? Things like our processed food, our sugars, our booze, our caffeine, looking at our sleep and our relaxation time, okay? Right. Top tips for nutrition. Let's look at specific nutrition, okay? Now, it goes without saying, making healthier food choices, avoiding your high processed, your high cal foods, but in particular, calcium. Not just in dairy, but also in nuts, salmon, dark green leafy veg. You're looking at 700 milligrams a day. So, but you get about 600 milligrams of calcium in a pint of milk. So you should be having about 700 milligrams a day for your bones. Your essential fats, that's your avocado, your olive oil, your oily fish. Your phytoestrogens, like your soya, your flax seeds. Magnesium, big fan of magnesium myself. Helps with sleep, helps with muscle relaxant. It can help with restless legs, which we see an increase of at this time of life. And again, your dark green leafy veg or your supplements. And you're looking at about 300 milligrams a day for that. And what I said before about your diet, you know, if you can aim for a 12-hour fast overnight, so say you have your dinner at 7, don't eat till your breakfast at 7 in the morning. That's basically, there's a theory that switches your body into a fat burn state, okay? And likewise in the day, go for a minimum of a 4-hour gap between your meals, okay? So I'm telling you all of this, but why is there still some negativity around HRT? What is all the hype? Well, I'm going to summarise it by telling you about 2 trials that took place about 20 odd years ago that are still being talked about today. Now, there was the Women's Health Initiative trial in 1998 that was published in 2002, and this looked at cardiovascular disease risk. And this was followed very soon after by the Million Women Study trial, which looked at breast cancer risk. Now, I'm going to summarise it by basically saying the trials were flawed. Okay, and in fact, the authors have even come forward. It's now accepted within the medical profession that both trials were flawed. So, for example, the cardiovascular trial actually looked at women over 60 who already had cardiovascular disease. So, of course, you give them HRT, they've already got cardiovascular disease, okay? So as a profession, we do accept that these are flawed. And thank goodness, we now have an extra 20 years of research under our belt. Okay. So in 2019, the Lancet said, hang fire, let's just have a look at this. Let's collate all this evidence. Let's put it all together and let's have something concrete we can give the public and the profession. So what they said was, they looked at all this myriad of trials and they said, okay, there is a small increased risk of breast cancer with HRT, but the risk should be considered in comparison to the risk with other lifestyle factors such as alcohol and obesity. Now, if you're going to see me or your own doctor, nurse, pharmacy about HRT, right? And they say, oh, yeah, so is there a risk of breast cancer with HRT? Oh, yeah, well, there is sort of a bit of a risk. I don't know, it maybe goes from this to this. I don't really know. That is not helpful, is it? That doesn't help you and it doesn't help me. Okay, so what we need are some figures. Okay, now what we're going to do is we are going to take a group of 1,000 women between the ages of 50 and 59 and we're going to follow them for 5 years. Okay, 1,000 women followed for 5 years. The background risk of breast cancer for those women is 23 cases per 1,000. So 23 of them are going to get breast cancer through no reason other than that is life. Okay? Right. Now, let's take that same group of women and give them combined HRT. Okay, let's follow them for 5 years. All right. We're now seeing an extra 4 cases of breast cancer per 1,000. Okay, that's interesting. Small. Okay, it's there. Oh, hang on a minute. Let's take that same group of women. Don't give them HRT. This time, give them a glass of wine a day. Oh, okay. So having a glass of wine is more risky than having HRT. I've never in my life had a girlfriend say to me, oh, I don't want that glass of wine, thank you, Kathryn, because I'm worried about my breast cancer risk. I've never heard anyone say that, but I have heard women say, oh, I can't take HRT because it gives you breast cancer, doesn't it? So it's quite interesting, isn't it, putting that into context. Now, let's take the same group of women. Don't give them HRT. Don't give them booze. Give them 20 Marlboro Light a day, okay? Make them smokers. What happens now? Okay, we're getting an increased three cases per 1,000. Now, let's take the same group of women. This time, no HRT, no booze, no fags. Here's what we're going to do. We're going to make them all obese. Look what happens to the numbers now. Now we're getting an extra 20 to 30 cases per 1,000. So we've gone from a background of 23 to up to 53 women per 1,000. So in other words, being obese is 7 to 8 times more risky than actually taking HRT when it comes to your breast cancer risk. It's pretty powerful, that, isn't it? It's all about context, isn't it? Now, you know what I said to you, exercise, it's your best friend, isn't it? This is another reason why, all those reasons I mentioned before, but also if you exercise 2.5 times a week, right? I'm not trying to make you the next Mo Farah. I'm just saying, go for a power walk for half an hour, 5 times a week. Okay. Do it with your friend, make it sociable as well. You get 7 fewer cases per 1,000 over that period. So that number goes from 23 down to 16. Interestingly, if we give these women estrogen only HRT, remember this is for women who've had a hysterectomy, their risk decreases by 4 per 1,000. Okay, so we know it's the progesterone component of HRT that contributes towards breast cancer risk. But we also know that that is more with the synthetic progesterones. And remember this one from before, your lovely little pearls. This is what we call breast neutral at 5 years. So in other words, take that every day for 5 years, no increased risk breast cancer. And the data on the 5 to 10 years is emerging as we speak. Okay. So what about older women? So, you know, I get often asked about this. I think because there's more attention in the media now, we're seeing women in their 60s who are coming forward saying, well, actually, I was told to put up and shut up, but I'm still got my symptoms. Can I have HRT? Well, there's little evidence available on starting HRT in older women. Remember what I said before, if you start it under 60 or within 10 years of your last period, it'll reduce your there is no cardiovascular increased risk, and if anything, it'll lower your risk. Research hasn't been done yet, but as I say, it's being conducted as we speak. This is what's emerging all the time. Now, most women who are otherwise fit and well will still gain benefit from taking HRT, even if it has been more than 10 years since their menopause, and even if they are over 60. Older women will often need a smaller dose of HRT. I would be saying absolutely go for the transdermal, but you know me, I like my gold standard. I'm going to be going transdermal anyway. Okay. And it is about individual discussion. So what next? What should we do next? Well, we need to talk more about it, don't we? We need to destigmatize it, okay? We need to be talking about it amongst your friends, your social group, in your workplace, please, in your workplace. HRT can be a lifeline for some, but also remember your non-HRT options, especially your activity, okay? Fortunately for us all here, the world is becoming more enlightened, and so is the profession. I still think it's fair to say that menopause really is puberty's evil older sister. So moving forwards from here, what should you do? Okay, if any of you here tonight, now some of you might be thinking about HRT, some of you might already be on HRT. If you feel you wish to try it, or you're on it and you feel it needs tweaking, okay, what I would recommend you do is submit, if you've got either Ask My GP or e-consult at your surgery, some of you phone for an appointment. When you do so, please, please tell them that you've attended this webinar this evening. I've been to Dr. Patrick's webinar, okay? Because most of the practices in Somerset know that I'm doing this, okay? So they will have heard of me, they'll know what I'm doing. And at the risk of blowing my own trumpet here, they'll know that you've had reputable information that is safe and reliable. So in other words, you've not just gleaned your information from mum's net or something similar, okay? Please send in your body mass index, which you can work out online. Just Google body mass index, put in your height and your weight, send in your BMI, send in your blood pressure. We can have a look on your records when your smear is due, if you've got a mammogram due, and we can also look at your case in individual, look at your individual case basically and see if that is appropriate for you. Anybody here wishes to consider a Mirena coil as part of their HRT? Remember what I said, perimenopausal women might want a Mirena because they might be thinking, oh, actually, this is good contraception as well. Do ask at your practice if there's anybody who fits there. If not, ask if there's anybody within your primary care network, because a lot of us, what we're doing now is we're teaming up with practices in surrounding areas. So, for example, I fit coils at my surgery, but I also do them for patients from other surgeries as well. The Balance app, huge fan of this. I actually know Louise Newson, who is the founder of this Balance app, and I'm going on record to say that I've been recommending, Sarah will testament to this, won't you? I have been recommending the Balance app long before I ever met Louise Newson, okay? It's a free app. There's an option to upgrade if you wish for more in-depth information, but to be honest, there's shed loads of information and resource even on the free bit. So please, please look at the Balance app. Rock My Menopause, that's another reputable resource, okay? We will send all of these details to you, do not worry. We've got your emails from joining tonight, so we'll be able to ping you a list of all these reputable resources. And now I'm going to have a quick drink of water while we take some questions. Thank you for listening. Thank you for staying with us. The numbers, we've still got numbers, Sarah. I'm so pleased. Well done.
Thank you so much, Dr. Patrick. Thank you. On behalf of everybody, that was just so informative, but also the delivery was absolutely brilliant and so entertaining. So we're all incredibly grateful.
Oh, thank you.
We are going to now move on to the questions. So I am going to now stop recording so that you feel free to ask questions, freely and openly without being recorded. So I'm going to stop that now. There we